So I want to spend the rest of the time talking about the tendons, both general anatomy and normal characteristics, and their pathology. So we can break it down to 4 groups of tendon: the posterior group here, the medial group, the anterior group, and the lateral group. Now the posterior group, or the posterior tendons, consists of the Achilles, most importantly, then plantaris tendon, which is this little dot anteromedial to the Achilles and seen in about 90% of patients. And very occasionally, you'll see this anterior to the Achilles, which is the accessory soleus muscle, and you'll just notice that it has the same signal intensity as adjacent musculature. It's an uncommon anatomic variant. The medial tendons, you might remember from medical school, the mnemonic Tom, Dick, and Harry. That refers to the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus. As an aside, any tendons in general in the body that change direction at some point along their course have a synovial sheath for protection. And note that the synovial sheath of the tibialis posterior tendon actually ends about 1 to 2 centimeters prior to its navicular insertion. We'll talk about why that's important in a little bit. The anterior tendons, I use the mnemonic Tom hates Dick, and that refers to the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus. Sometimes you can have a little what's called a peroneus tertius, which sort of extends from the extensor digitorum longus, but usually that's not an issue. Lateral tendons consist of the peroneus brevis, which is located anteromedial to the peroneus longus and may normally appear quite flat near the fibular tip, or the peroneus longus, which is seen posterolateral to the peroneus brevis and is more rounded. Now, tendons should be hypointense on all MRI sequences, with the exception of the distal posterior tibialis tendon and the Achilles, which often appear slightly heterogeneous near their respective insertions. Also, segments that course at or near 55 degrees in relation to the static magnetic field will often undergo the so-called magic angle effect and will have a little bit of spurious increased signal on short TE images such as T1 and proton density. A small amount of fluid may be seen in the tendon sheaths of asymptomatic patients, but fluid is abnormal around the Achilles because, as we said, the Achilles has no tendon sheath. The distal posterior tibialis tendon, because the tendon sheath ends about 1 to 2 centimeters prior to the navicular insertion, as well as any anterior tendon. So let's talk about these tendons in detail. Now I'll start with the Achilles tendon. I tell my residents I refer to this as the happy tendon because it's the largest and strongest tendon in the body. It's free. It lacks a connective tissue sheath. It instead has a very loose connective tissue peritoneum, and it kind of looks like it's smiling. It has this concave or flat anterior border in the axial plane beneath the soleus insertion, and that's normal. Interfascicular membranes may normally cause little punctate areas of high signal in the distal tendon on axial images. That's completely normal. On the sagittal planes, the anterior and posterior margins of the Achilles tendon should be parallel below the soleus insertion, and you should see nice homogeneous fat anterior to the Achilles in what's called Kager's fat pad. There's a little bursa called the retrocalcaneal bursa that protects the distal Achilles tendon from the posterior calcaneus. It's normally about 2 to 6 millimeters and can be filled with a little bit of synovial fluid, but if you have distension, as you see here, that's going to indicate a retrocalcaneal bursitis. There's another bursa called the retroachilles bursa, which is an acquired or adventitious bursa. That just means that you're not born with this, but it results from ill-fitting shoes, etc. And it's a bursa that's posterior to the distal Achilles tendon, situated in the subcutaneous fat. Now, as far as injury and pathology goes, you can classify it broadly into non-insertional and insertional. Non-insertional is the usual region of Achilles rupture. It's about 2 to 6 centimeters proximal to the calcaneal insertion in a zone of relative ischemia. It often follows acute trauma in poorly conditioned athletes in the 3rd to 5th decades. Insertional injury is less common. It's associated with Hagelin's deformity of the calcaneus, which we'll talk about in a little bit, as well as ill-fitting shoes and overuse syndromes, particularly in runners. Let's talk about just the different terminology. Peritendinitis, peritendinitis, tendinosis, partial tear, and full thickness tear. We'll talk a little bit about each of these terms. Some of them are interchangeable. Peritendinitis is really the first symptomatic stage of Achilles tendon disorders, and this is what clinicians will refer to as tendinitis. Basically what you see on MRI is a high signal zone limited adjacent to the posterior aspect of the Achilles tendon on fat-suppressed T2 weighted images. Peritendinitis, on the other hand, really refers to edema not only here, but in Kager's fat pad as well, all around the tendon. A lot of people use these terms interchangeably, and I think that's fine because they're both going to be treated conservatively. Tendinosis occurs about 2 to 7 centimeters proximal to the calcaneal insertion, and we prefer the term tendinosis to tendinitis because if you actually were to go in and biopsy this tendon, you really wouldn't see any inflammatory cells. They're all degenerative. So although the clinicians call it tendinitis, really it's a degenerative phenomenon in most cases. It's going to manifest as tendon enlargement. And on sagittal images, instead of seeing the nice cord-like Achilles tendon, you see this fusiform Achilles tendon here. And on axial images, instead of smiling, it now looks like it's kind of scared. You have this convex anterior margin below the level of the soleus insertion. You can also, with tendinosis, see these little foci of round or ovoid high signal intensity on T2 weighted images between the degenerative fibers, and these are just vacuoles, mucoid vacuoles that can eventually coalesce into an interstitial tear. And interestingly enough, there have been some reports that show if you have this kind of tendinopathy as opposed to just the fusiform tendinopathy or hypoxic tendinopathy, these patients tend to be a little less symptomatic. I reserve the term partial tear for when I see incomplete interruption of the tendinous surface, as you see here. It can be difficult, however, to differentiate this from severe tendinosis. It is a spectrum of injury in many cases. Acute tears, though, are going to be associated with edema in the surrounding fat, unlike tendinosis in most cases. A full thickness tear usually is not a problem clinically or on MRI, but what you want to be sure to do is describe the length of the gap. If it's greater than a centimeter, then these patients are usually going to go on and get surgery. But one treatment, if it's less than that, is to actually cast the patient in plantar flexion. And then your orthopedic surgeon might ask you to get an MRI after casting to see if the torn edges are abutting one another. Now, insertional injury and pathology is less common, but you see enlargement and increased signal intensity within the tendon at the insertion site. You might see a retrocalcaneal or retroachilles bursitis, and you might see large posterior calcaneal enthesophytes, as you see here. I said I would talk about the Haglund's deformity. This is important to notice. It's basically a little spur that occurs here along the posterior calcaneal tuberosity, not down here like that enthesophyte I showed you, but up here. It's associated with pump-style shoes and has been called a pump bump in the past. It can also be congenital, but what can happen is sort of a vicious cycle. It can irritate the bursa in the tendon, cause a insertional tendinopathy, and this in turn can cause more bony proliferation and lead to this vicious cycle of Haglund's syndrome. Let's move on now and talk about the medial tendons. I refer to these as the sad tendons. They're sad because they may normally cry. You can see fluid within the synovial sheaths in normal patients. Also, the tibialis posterior is sad because it's always second. It's the second largest ankle tendon, or even the third behind the tibialis anterior, and it's the second most commonly injured. Now, the normal tibialis posterior tendon should be about twice the size of the flexor digitorum longus or flexor hallucis longus. Again, a small amount of fluid in its sheath is normal. And we're talking on the order of 1 to 2 millimeters, almost never circumferential. When it is, then I raise the possibility of a tenosynovitis, and never in the distal 1 to 2 centimeters, because as we said earlier, there's no sheath there. The portion of the tibialis posterior tendon that's most susceptible to injury lies right behind the medial malleolus, where the tendon is most subject to friction, stress, and ischemia. Now, as far as injury and pathology goes, it's typically a chronic process of overuse that represents a spectrum of pathology that we're going to call tibialis posterior tendon dysfunction. This occurs primarily in middle-aged and elderly women, and the patients often present with swelling and tenosynovitis in the early stages, followed by a flat foot deformity once the muscle tendon unit becomes insufficient from tearing. Acute injuries do occur, but they're less common. They can occur in young athletes, particularly basketball, hockey, tennis, and soccer players, and often near the distal insertion. Clinically, the first presenting stage is actually a peritendinitis or a tenosynovitis. You'll call it a peritendinitis if you see high signal around the distal tendon where there is no sheath, or a tenosynovitis if you see fluid around the tendon more proximally where there is a sheath. The tendon itself may or may not appear normal. What we usually see is tendinosis or tears. In tendinosis, you'll see an enlarged tendon with or without internal signal heterogeneity. Tears have been historically divided into type 1, type 2, and type 3. Type 1 tear or a partial tear, you'll see enlargement of the tendon. Now, instead of being 2 to 3 times as large as the adjacent tendons, it's 5 to 10 times larger than the flexor digitorum longus, and you'll see intratendinous foci of high signal. Type 2 is a tendinous attrition process where the transverse diameter actually decreases to less than that of the other flexors, and the signal intensity may or may not be altered. Usually it is. Type 3 is unusual, actually, and that's just frank rupture of the tendon where it becomes discontinuous. And as with the Achilles, there's a diagnostic overlap between severe tendinosis and partial type 1 tears, and can be a little bit confusing. For example, this could either be a type 1 tear or really bad tendinosis. You have a markedly enlarged tibialis posterior tendon. It's much more than twice the size of the adjacent flexor digitorum longus, has a little bit of high signal within it. Often you see these little spurs here next to the tendon in patients who have posterior tibialis tendon dysfunction, particularly in a chronic process. This is clearly a type 1 tear. There's actually a linear cleft going through the tendon extending to the surface. It's larger than the adjacent medial tendons as well, so we'll call that a type 1 tear. Here's an example of a type 2 tear where the tendon is actually now smaller than the flexor digitorum longus and flexor hallucis longus, or at least the same size. It has abnormal increased signal and fluid around it, so that's a chronic attritional tear or type 2 tear. I want to show this case here. This is a 51-year-old female with right ankle pain, and our requisition said rule out fracture or osteomyelitis. And if you look carefully, there is a little bit of periosteal reaction here along the medial malleolus, and the patient, it turns out, also had a mild flat foot deformity. Well, if you look at the MRI, you see that there is a type 1 tear. The tendon is cleaved. And if you look very carefully in the T2 weighted images, there's a little bit of edema right here in the medial malleolus. Here it is on the axial images, and here it is on the coronal images. Now, you can see this edema signal in the medial malleolus in patients with posterior tibialis tendon dysfunction. This does not necessarily represent osteomyelitis. If you have a chronic tendon process, the adjacent bone marrow can get edematous. The flexor hallucis longus tendon, we don't see ruptures or dysfunction of this as often. It's a tendon here that passes through a fibroosseous tunnel between the medial and lateral posterior talar tubercles, and this is where you're going to get injury. The synovial sheath of the flexor hallucis longus tendon may communicate with the ankle joint. This explains why a lot of times you'll see a lot of fluid around that tendon. Injuries tend to occur in athletes who perform extreme plantar flexion and push-off maneuvers, particularly ballet dancers, and that can be accentuated by an accessory os trigonum. The os trigonum, this is not an example of one, but this is a patient who has a flexor hallucis longus tear, and you see the adjacent lateral talar tubercle has a lot of edema within it. This is what forms the os trigonum if it never fuses with the underlying talus, this little tubercle right here. The anterior tendons, I refer to these as the angry tendons because Tom hates Dick, because they don't cry. Fluid around the tendon is abnormal, as you see here, around the tibialis anterior. And tibialis anterior injury, although rare, tends to occur in grumpy old men, particularly with gout or patients with systemic diseases such as diabetes or rheumatoid arthritis, more so than in younger athletes who are runners, skiers, or kicking athletes. Here's an example of tibialis anterior tendinopathy. And in fact, you have to keep in mind that patients who have these types of tears may present actually with a mass, and the clinician may order an MRI to rule out tumor. You can certainly see how this would be mass-like, but when the orthopedic surgeon went in here, he actually just took out loads of gout from the tendon and the tendon sheath itself. So in my experience, in several cases, these anterior tendon tears are associated with gout. Let's talk finally about the lateral tendons. I refer to these as the crowded tendons. They're crowded because they share a common tendon sheath approximately to the level of the fibular tip, at which point they diverge, each within a separate tendon sheath. So how are these peroneal tendons going to cope with these crowded conditions? Well, one of them can say, I'm going to cry, meaning it'll develop fluid within the sheath, i.e. tenosynovitis. But remember, a small amount of fluid around these lateral tendons can be normal. Or they can say, I'm going to split, meaning it'll form a longitudinal tear. But this actually may not be clinically significant, especially in the elderly population. They can have these longitudinal tears but be completely asymptomatic. Or they can say, I'm going to move, in which case they dislocate laterally, and this usually has to be followed by detachment of the superior retinaculum. Peroneus brevis injury is going to be more common than injury to the peroneus longus. You usually don't see peroneus longus injury unless you have peroneus brevis injury. So tenosynovitis of the peroneal tendons, you'll usually see excessive fluid and fibrous bands within the tendon sheath, but repetitive stress can lead to hemorrhagic synovium and so-called stenosing tenosynovitis or peritendinosis, and sometimes the fluid will actually have some low signal intensity within it because of the hemorrhage and the synovitis. Sometimes you just may see a big glob of low signal around the tendons. This is a so-called peritendinosis or stenosing tenosynovitis. Longitudinal tears of the peroneal brevis are usually preceded by chronic tendinosis, either thickening or increased signal, just like in any other tendon. You can see the Mickey Mouse sign with a longitudinal split, where it looks like little ears there, the split tendon. Too many tendons. There's only be 2 tendons here. It looks like you have 3. That's a split peroneus brevis. There's a normal peroneus longus. You can also get just a boomerang or C-shaped tendon. It can be a little bit flat, but as soon as it gets boomerang or C-shaped, you have to worry about a tear. And here's an example of a peroneus longus tear. It's torn in about 30% of individuals with peroneus brevis tears. And finally, these tendons can sublux, particularly if the lateral ligamentous structures are insufficient, the superior peroneal retinaculum is insufficient, or if you have an abnormal morphology to the peroneal fibular groove. Usually the tendons should be sitting posterior to the fibula, but when they sublux lateral to the fibula. So in conclusion, the differential diagnosis of bone marrow edema in the foot and ankle is not limited to osteomyelitis. Certain features may point instead to neuroarthropathy, fracture, or other etiologies. An adequate evaluation of the ankle tendons requires a solid understanding of both normal anatomy and morphology, as well as the knowledge of the injury patterns. Thank you very much.
Our next talk, for the next 20 minutes, we're going to be talking about magnetic resonance imaging of the shoulder. And after the knee, this is perhaps the second most common joint that we image. The shoulder is sometimes confusing to residents and practicing radiologists, and there are a lot of alphabet soup ingredients to remember. We're going to talk about all these: Glad lesions, Alpser lesions, Hagel lesions, Bagel lesions, SLAPS lesions, Tubbs, Ambry, and PSGI. And hopefully at the end of 20 minutes you'll at least have some idea of what these mean. Our talk is sort of organized. We're not going to talk that much about technique. We're going to talk about normal anatomy, glenohumeral instability, impingement, and then some other pathology. Routine sports medicine, this is sort of our basic sequence. We do an axial and the oblique coronals, and we'll talk about that a little bit. Let me talk just a little bit about MR arthrograms, because we are doing more and more shoulder MR arthrograms. And they include a very dilute solution of gadolinium that's injected into the joint. You do have to have the patient sign a consent for this, because intra-articular injection of gadolinium is not specifically FDA approved. Well, who do you do an MR arthrogram on? I think if you look at your patients in general, you have the older patients with rotator cuff tears, and you have the younger patients with instability. So basically, if you just divided them above and below 30, you'd probably be correct most of the time. But really what we do it for is suspected labral tear, unstable shoulder, looking at the glenohumeral ligaments. We're going to look at them today. If you're looking for loose bodies, post-op shoulder, and difficult cases where you really can't tell the difference of a partial tear from a full thickness tear. Now, just a little bit about the anatomy. We all know the rotator cuff, and here are the four muscles of the rotator cuff. Here's an anterior view of the subscap, and just the bursa. We're not going to go. What I do want to show you is the suprascapular notch, which is here with the nerve in it, and then going down posterior, there's the spinal glenoid notch with the suprascapular nerve in it, because that's going to be an area of entrapment. These are not projecting all that well to me. Here we have communication of the joint with the subscapular recess, foramen of Rouvier, and the foramen of Weitbrecht. Posterior view. Now you can see the axillary nerve is coming down here, and a branch of the axillary nerve actually innervates the teres minor, and that's a different sort of nerve injury that we'll talk about later. Just another view. Just a cut section of the glenohumeral joint. Here's the joint. Here's the subdeltoid, subacromial bursa, axillary recess. Looking down into the joint, this is the glenoid labrum. We're looking right into the glenoid fossa. Okay, let's look at MR examination on our axial views. You can see the supraspinatus coming over. Just very briefly, supraspinatus. The head on the first slices should be round. And as we go down again, it's round, infraspinatus, subscap in front. This is that spinoglenoid notch. It's full of fat and nerves, and it's an area that where you can have nerve entrapment. Glenoid labrum, anterior and posterior, and you can see how this cartilaginous labrum adds at least 50% of the depth of the glenoid fossa, so it's very important for stability of a shoulder. Biceps tendon, long head of the biceps, is in its groove. Now, we also do these oblique coronal images. If you go back, these are going to be in this plane. And here's a nice fat supraspinatus that looks normal. A little gadolinium in the joint, biceps tendon, which the tendon sheath communicates with the joint, of course. Okay, as we come on out into it. Okay, and here's subscap coming across. And these are just images showing the bicipital labral complex as it comes off the superior labrum. Okay, and our oblique sagittal images, which are equivalent to a wide view. So here's supraspinatus, anterior subscap, infraspinatus. A little fluid in the subscapular recess, which is a normal part of the joint. And here we're looking into the glenoid fossa, and you can see this bicipital labral coming off. Okay, 12 o'clock supraspinatus, anterior subscap, infraspinatus teres minor. Okay, let's talk about the glenohumeral ligaments real briefly. I don't know where I was in anatomy class when I was in medical school, but I never heard of the glenohumeral ligaments. And it was not until we started doing a lot of musculoskeletal EMR that we really started talking about the glenohumeral ligaments and their importance to stability of the shoulder. And they're really not that difficult, the most important being the anterior-inferior, but there's a superior glenohumeral ligament. And we're looking into the joint. This is the bicipital labral complex. That's the biceps tendon. This is the superior labrum. We're looking down into the joint, sort of like a Y view. Superior glenohumeral ligament, middle glenohumeral ligament, and there's a posterior and anterior inferior glenohumeral ligament. And my concept of how to remember where these go is the Zorro idea. And if you look at this diagram, this is the humeral head, and here's the glenoid fossa. And the superior ligament, glenohumeral ligament, comes off the superior labrum to the humeral head. The middle comes across here, and the inferior, the two inferior, they make a nice Z. Okay, so let's look at MRs of these glenohumeral ligaments. Here we can see the superior glenohumeral ligament coming off the superior labrum, and it joins with the coracohumeral ligament to insert on the humeral head. So if you can find this coracohumeral ligament, you can find the superior glenohumeral ligament. The middle glenohumeral ligament is either flattened like this or it can be somewhat rounded, and you see it very frequently adjacent to the anterior labrum, and it can almost look like a labral fragment, but you can follow this on sequential axial images as it goes down. And then the inferior, the anterior and posterior inferior glenohumeral ligaments, and like I said, this is the one that's most important for stability. Now here's another anterior and posterior inferior glenohumeral ligaments. Sometimes you don't really have discrete ligaments. You'll have it all fanning out down in the axillary recess, and that's sort of a normal variant. Now, there are some normal variants, especially in the anterior superior labrum. If you have an isolated abnormality in the labrum that's anterior superior, it may be a normal variant. There's a sublabral foramen that's between 12 and 3 o'clock, and here we can see a defect. You can see a defect there in the anterior superior labrum. And you can also have an absent anterior superior labrum called the Buford complex, and they tend to get a very thick middle glenohumeral ligament. So you'll see a cord-like middle glenohumeral ligament and an absent anterior superior labrum. And here's a view. This is an axial view. This is the glenoid. Here's the anterior labrum, posterior labrum. The humeral head would be here. And here's a normal MGL sitting adjacent to the anterior labrum. Now, with this Buford complex, what happens is you don't have an anterior labrum, but you have a big fat MGL. And here you can see no labrum, but a big fat MGL. And here's another one. Here's osseous glenoid, but no cartilaginous labrum, and a big fat MGL. Now, glenohumeral instability actually has become simpler in the last few years, where we used to talk about a lot of different categories of glenohumeral instability. Now we can basically divide them up into two categories, TUBS and Ambry. TUBS is traumatic unilateral Bankart surgical. This is a patient that has the anterior dislocation. It has a good surgical result, a fairly good surgical result, and this is the one that you really want to image and look for the labrum. Ambry those are the patients you don't want to have. These are the patients that don't do well. They don't do well surgically. They're multidirectional, bilateral, atraumatic instability. Now, let's talk about labral pathology, SLAP lesions, and then we're going to talk about the Bankard lesions and the Bankard variants. I think if you group all these together, they're sort of Bankard variants. SLAP lesions, superior labrum, anterior, posterior. Originally, they were 4 classifications, and now they've gone on to 9 and then to 12. But I think if you can recognize the basic 4, you're ahead of the game. So the original classifications, type 1 is fraying in the superior labrum. Type 2 is a tear of the superior labrum. Type 3 would be a tear of the superior labrum with a displaced fragment, sort of like a bucket handle fragment in the knee. And then a type 4, the tear extends into the biceps tendon. So here we're looking into the glenoid fossa. Here's the labrum in blue. Here's a little tear, bicipital labral complex. And here's a little fraying of the superior labrum. And these lesions tend to start posterior and go anterior. So an isolated anterior, remember we said, could be a normal variant. Type 2, here's a tear. Type 3, a fragment flips over into the joint. And a type 4, you see this tear going up into the bicipital labral complex. And here's a patient with a SLAP lesion in the superior labrum here and there. And in this one, you can actually see it going into the tendon sheath of the biceps. Okay, let's talk about these glenohumeral ligaments. In the anterior labral abnormalities, anterior inferior glenohumeral ligament, this is a normal humeral head. Here you can see the anterior labrum that's normal. Now, a classic Bankard lesion, the periosteum is torn, and the labrum, the anterior labrum is just pulled off. And this is the anterior inferior labrum. That's your classic Bankard lesion. But actually, before Bankard described his lesion, Perthes described what's called a Perthes lesion. And here we have the anterior fragment pulled off, but the periosteum is still intact, and frequently it fibroses back down. So this is the one that you want to find, because the orthopedic surgeon may not see this, he may not probe this anterior labrum and realize that there is a fragment that is fibrosed back down to the normal labrum. ALPSA lesions are sort of a medialized Bankard. Think of them just as a medial fragment that's been displaced. Anterior labral periosteal sleeve avulsion. And here's a young patient, 18 years old. The humeral head is abnormal. You can see there's a Hill-Sachs deformity from a previous anterior dislocation. And if you look at his anterior labrum, all of a sudden you don't see a cartilaginous labrum. And inferiorly, there's this displaced fragment. So this is an ALPSA lesion. Here's another one. The fragment is displaced and medialized. A Perthes lesion, the fragment is fibrosing back down in an almost normal position. And here's our classic Bankard, where we just don't have posterior labrum, we just don't see an anterior labrum. Here's another patient with a displaced fragment and a Hill-Sachs deformity. Now, GLAD lesions, glenoid labral articular defects, these are not that important, but I want to make you aware of them. They are usually stable because the labrum is not detached, but the patient may have pain or clicking or locking. And here's a little defect, articular defect at the base of the labrum, and you can see that there. And here's another one right there. Okay. Injury to the inferior glenohumeral ligament, Hagel's and Bagel's, humeral avulsion of the glenohumeral ligament, humeral avulsion with a bone fragment. Usually the avulsions at the glenoid. Here's one that is in the middle of the inferior glenohumeral ligament. So this is not common. Okay, let's talk now in the last few minutes on rotator cuff tears. There was an orthopod named Neer that popularized this theory of impingement. And impingement is really, extrinsic impingement is really a clinical diagnosis. And his idea was that external impingement had 3 stages. You started with edema and hemorrhage in the rotator cuff, and eventually went to fibrosis. And then the end stage of impingement was a rotator cuff tear. And he thought that almost all rotator cuff tears were not post-traumatic, but the end stage of this degenerative process. Now, the causes of an external impingement, probably the most common thing we see is OA at the AC joint. You see big osteophytes or enthesiophytes at the AC joint, but you can also have a type 3 acromion. I'll show you a diagram of that. Lateral downslope to the acromion, capsular enlargement. You can have a normal space, but you have an athlete who's a swimmer who has a big rotator cuff. And you can also have an unfused ossification center, an os acromiale, but be careful in young patients because they can normally have an unfused ossification center there. Okay. Now, if you look at this diagram, this is a normal acromion at the AC joint, nice flat undersurface. Here's a type 2 where there's a general downsloping, and then there is a beak-like type 3 acromion, and this is the one that's thought to be associated with external impingement. You can also have lateral downsloping of the acromion. Here's a patient with an os acromiale. It's seen best on this CT. Now, internal impingement is not as common. This is really a thrower's shoulder. You have a young athlete and complains of posterior pain. They get compression of the posterior rotator cuff between the posterior labrum and the humeral head. So posterior superior glenoid impingement, PSGI. And it's not common, but it's something that you need to be aware of. The classic triad is undersurface rotator cuff tear posteriorly. Most rotator cuff tears are going to be anterior. They're going to be in the supraspinatus, specifically anterior supraspinatus. These are posterior tears, especially in the infraspinatus. They get posterior superior labral injuries, and they can get cystic changes in their humeral head. And this is a patient, recent patient, has this cystic change in his humeral head with an internal impingement syndrome. And perhaps his labrum is a little fuzzy back here, although I did not see the underlying infraspinatus tear. Now, let's talk about rotator cuff tears within the last few minutes. They can be partial. I want to make you aware of rim-rent tears. These are young patients, full-thickness tears in massive. And you want to be able to describe them as intrasubstance, bursal substance, articular surface. Okay? Etiology of rotator cuff tears, like I said, Neer said it was the end stage of external impingement, trauma, degenerative changes, secondary impingement in athletes. What's wrong with Neer's theory? Well, most partial tears are on the articular surface rather than the bursal surface. So if you're getting external impingement, doesn't make that much sense. Rotator cuff tears, of course, occur without AC pathology, and a type 3 acromion is acquired, not developed. So Neer is probably right most of the time, but it's not a foolproof theory. Critical zone is the most common, anterior supraspinatus most common, and rim-rent tears are young patients that have partial tears at the insertion. Normally, you have decreased signal on PD and on T2. With tendinopathy, you have increase on PD, increase on T2, but not as bright as fluid. Secondary signs of a rotator cuff tear, loss of peribursal fat pads, bursal fluid, articular fluid, intertendinous signal, intramuscular ganglion. But the primary tears are discontinuous tendon and retracted tendon. So here's a patient that has a PD and a little bit of increased signal T2, and it's a tendinopathy. Here's that same patient, a little fluid in the subdeltoid bursa, but no rotator cuff tear. Here's another one, proton density T2. This is tendinopathy. Another patient, a lot of increased signal here on the T2, however, it does not get as bright as this fluid. And again, tendinopathy. Again, a patient with tendinopathy. And this patient actually had calcium hydroxyapatite deposition. And here you can see this calcium hydroxyapatite. It's seen best on a plain film, and you can see that it's in the supraspinatus. Here's a partial tear, and this was a partial tear of the subscap, and those are associated with dislocation of the biceps. In the last minute, let's look at some full thickness tears, intramuscular ganglion associated with labral tear, with rotator cuff tears. And when you see this, look very hard for the rotator cuff tear. Rent tears, I said, are young patients that are very much at the insertion. And another tear, and full thickness tear. Again, full thickness tear. And let me just end up with something, a couple things I want to make you aware of. One is called the geyser effect. Here we have a chronic rotator cuff tear, and the fluid is going into the AC joint. And what happens is you get this chronic rotator cuff tear, fluid goes up into subacromial bursa and into the AC joint, and voila, a geyser, and they present with soft tissue masses. Here you can see this chronic rotator cuff tear in the soft tissue mass. And here's another patient that presented with a soft tissue mass. Suprascapular nerve entrapment. Like I said, look at the spinoglenoid notch. These patients get big ganglion cysts that are thought to arise from labral tears. Here's one that we aspirated. And they can end up with atrophy of the supraspinatus and infraspinatus, depending on where it is. Here's a lot of atrophy in that patient. Axillary neuropathy quadrilateral space syndrome is also something to be aware of. It tends to involve the deltoid and the teres minor. And just to finish up, be aware of idiopathic brachial neuropathy that has no cause. This is really a diagnosis of exclusion. A patient with Parsonage-Turner syndrome looks like they have a nerve entrapment syndrome, but you do the exam on this patient and you see no cause because it's idiopathic. Okay, thank you very much.
Okay, thank you very much. And for the next 20 minutes, I'm going to be talking about MRI of the hip. And specifically, what we're going to talk about are marrow patterns that we see in the hip, both normal and abnormal, and articular and soft tissue causes of painful hip, osteoarthritis, labral pathology, bursitis, and briefly myotendinous injury. So let's start off by talking about marrow. At birth, as we all know, the skeleton is composed predominantly of red marrow, but this red marrow undergoes orderly conversion to yellow marrow, and there's several patterns that you should be aware of. In the skeleton in general, this conversion begins in the extremities and eventually makes its way to the axial skeleton and flat bones. In the long bones, this conversion begins in the epiphyses or apophyses, then moves to the diaphysis, and the last place to convert to yellow marrow is actually the metaphysis. And in any bone in general, the conversion starts centrally and works its way out peripherally toward the subcortical regions. Now, this marrow conversion may actually be completed by a patient's mid-20s. The rate of conversion, as well as the amount and distribution of residual red marrow, is going to vary from adult to adult. Some adults will have no visible red marrow in the proximal long bones, whereas others will have quite a bit of red marrow persisting in the proximal femur and proximal humerus in the metaphyses. So how do you know what's normal and abnormal? We'll use some general rules. Rule number one is the amount and distribution of the red marrow should be symmetric. So you see in this patient here, there's still some red marrow in the spine and a little bit of red marrow in your metaphyses of both humerus. The epiphyses and diaphyses, though, are yellow marrow, but it's quite symmetric in this 30-year-old patient, so that's normal. Rule number two, some adults may actually have a small amount of subchondral red marrow in the proximal, femoral, or humeral epiphyses. Like you see here, this little curvilinear bit of red marrow should not be confused for avascular necrosis, which we'll talk about a little later. Rule number three is that, and this is important, since normal red marrow contains some fat cells, the signal intensity on T1 weighted images should be higher than that of muscle. So in this 9-year-old patient who has only undergone conversion in the epiphyses and apophyses, still quite a bit of red marrow in the metaphysis and diaphysis, but it's of higher signal intensity in this T1 weighted image than the muscle, so that's normal. Here's an abnormal case where there's still quite a bit of red marrow, but there's this area here that's as dark as muscle, so that's going to be abnormal marrow, and that turned out to be a metastatic focus. Now, there's several processes that can disrupt the normal marrow signal. One can have too much red marrow, either from failure of conversion or delayed conversion, or reconversion. If you're healthy and then fall ill, this can recruit red marrow in the reverse order of conversion. You can have infiltration of marrow, either by cells or by edema, and usually edema is going to be due to trauma or transient edema. And finally, you can have osteonecrosis. So let's talk about too much red marrow. Well, this can occur due to failure of conversion, either from anemia or chronic illness. Here's a 30-year-old patient. We know that by 30, you should at least have your epiphysis and your diaphysis be nearly completely yellow marrow, but here everything is still red marrow, still very dark relative to the muscles. This is abnormal. This person has sickle cell anemia. Delayed conversion, where you just have a little too much red marrow overall, can be seen in obese patients, those who are menstruating, smokers, athletes. This is a 50-year-old patient, has a little bit more red marrow than normal, but also has a little bit more adipose tissue than normal as well, so that's considered normal in that particular patient. Infiltration of marrow can be by cells, be it tumor or infection or other marrow packing disorders. In this particular patient, we see that there is some yellow marrow in the diaphysis, and based on the order of conversion, we know that there should be yellow marrow in the epiphysis and greater trochanter here as well, but you don't see it. Instead, you have this dark marrow, darker than muscle, and this person had lymphoma. Edema, of course, can cause infiltration of marrow, either trauma or transient edema. Here we have a nice example of an intratrochanteric fracture. Just as a side note, MRI is a great way to look for occult hip fractures, very cost-effective, very rapid, precise. It's really favored in preference to bone scan. It's equally as sensitive but more specific, and actually allows an immediate diagnosis, whereas osteoblastic activity on bone scan may actually be delayed in the elderly and only begin to occur as late as 72 hours following the actual injury. MRI is also both more sensitive and specific than CT. The American College of Radiology simply recommends a single T1-weighted coronal image to evaluate patients with suspected femoral neck fractures, as you see here. My personal recommendation is you get a T1-weighted coronal image, but sometimes you can have some pretty strange-looking marrow patterns. This is completely normal in this patient, just some striated marrow in the metaphysis, but I like getting a T2-weighted STIR coronal image as well, because it can kind of focus you in on smaller areas of bone marrow edema, like up here in the acetabulum, here's down here in the left ischium, as well as soft tissue edema, which we'll talk about in a little bit, some strain of your adductor muscles, which can be painful, and then get your T1 axial images to look for those acetabular fractures, as you see here, and compare it to the other side. And the ischiopubic bones, I find, are much better evaluated on the T1 axial images. And it's important because additional unsuspected fractures of the pelvis are seen in about a quarter of patients referred with a suspected femoral neck fracture if the patient does not have an actual femoral neck fracture. Don't confuse the physeal scar, normal physeal scar, for a fracture. It's curved, it's very thin, and it's located more proximally than the typical fracture. Stress fractures can be divided into fatigue fractures, which refers to abnormal stress on normal bone, and you can typically see these in the proximal femur, femoral neck of young athletes, and insufficiency fractures, where you have normal stress on abnormal osteoporotic or osteomalacic bone, which tends to occur in the pubic rami or the sacrum, as you see here, a lot of edema, and can also occur in the femoral neck in older patients as well. Transient edema of the hip, the etiology is really unknown. It predominantly affects men in their third to fourth decades of life, more so than women in their third trimester of pregnancy. One experiences an abrupt onset of progressive hip pain. Conventional radiographs may eventually show osteoporosis of the femoral head several weeks after the onset of symptoms, in which case you can then call it transient osteoporosis of the hip. And the usual resolution of symptoms and osteoporosis is within 12 months. Transient edema is detectable on MRI within 48 hours of symptom onset, and you'll see an edema pattern that involves the femoral head, neck, and sometimes the intratrochanteric region. It's going to be of decreased signal on T1 weighted images and increased signal on T2 weighted images, especially if they're fat suppressed. You will commonly see a joint effusion in the acute period, but the surrounding soft tissues otherwise will be normal. There is a differential diagnosis that includes early osteonecrosis, which we'll talk about shortly. Septic arthritis, you'll also have a joint effusion, but usually you see marrow edema actually on both sides of the joint. Osteomyelitis and neoplasm tend to be metaphyseal. They don't have to be. You might have soft tissue extension. The one that can sometimes be problematic is an intra-articular osteoid osteoma, but they're pretty uncommon. They occur in younger patients than transient edema. I'm going to spend a little bit of time talking about osteonecrosis. It refers to the death of bone secondary to ischemia. And there are two broad categories: post-traumatic, following a femoral neck fracture, and then other causes, which are usually due to impaired vascular drainage secondary to raised intramedullary pressure that leads to congestion and edema. And this is probably the worst case of osteonecrosis I've ever seen, basically involving the entire femur here. For those of you taking boards, you might want to remember a mnemonic that reminds you of various causes. Aseptic is a good mnemonic. It puts anemia, steroids, and ethanol up there. If you want to forget pancreatitis, you probably can. Trauma, idiopathic, which is actually very common, and collagen vascular diseases are important to remember as well. So MRI allows earliest detection of osteonecrosis on the best imaging modality, at least, for detection of osteonecrosis. It's 90 to 100% sensitive for symptomatic disease, and it's much more sensitive and specific than nuclear medicine. The earliest finding that you'll see is a very nonspecific edema type pattern, low signal in T1 weighted images and high signal in T2 weighted images, very similar to the transient edema that we talked about earlier. It can extend into the intertrochanteric area. Sometimes on a sagittal image, you'll see a little subchondral crescent in the anterior superior aspect of the superior of the femoral head, and that can allow differentiation from transient edema. But that's pretty uncommon, I think. Osteonecrosis in the days to weeks, you'll start seeing a central region of infarcted marrow that maintains a normal fat signal intensity. And then eventually you'll get this reparative margin here. This is active reparative tissue at the interface between the necrotic and the normal bone. It consists of thickened trabecular bone. The sclerosis you'll see on plain radiographs, and produces this peripheral border of low signal intensity on both T1 and T2 weighted images. You can also see vascularized granulation tissue just inside that reactive bone that results in a second band-like area of high signal intensity on T2 weighted images. This is the classic double line sign. This is virtually pathognomonic for osteonecrosis. It consists of this bright line and a parallel dark line right underneath it. Advanced osteonecrosis, well, you might see fibrosis of the subchondral bone, which is going to be dark on both T1 and T2 weighted images. A subchondral fracture. CT may actually be better for this, especially these newer multi-detector CTs can better define stage 3 disease, and this is the stage that usually requires surgical treatment. Epiphyseal collapse, you'll see focal depression of the subchondral bone. It's often easier to appreciate on the sagittal images. And finally, end stage is osteoarthritis. There's an example. The patient has sickle cell disease, has some abnormal marrow over here, and this right femoral head is just collapsed. Some mimics you don't want to get confused about. We talked about one of them before, the marrow that some adults have in the subchondral aspects of the proximal femoral epiphyses. Again, it's not quite as well defined. Follows the subchondral contour there. The fovea is where the ligamentum teres attaches. It has a medial location. You'll usually see the same thing on the other side. And a synovial herniation pit, also called Pitt's pit, is a cartilaginous or fibrous tissue ingrowth through a little cortical defect into the anterolateral neck, a little bit lower down than your typical AVN. So I want to move on now and talk about articular and soft tissue causes of a painful hip. Just briefly, degenerative joint disease. We all know what it looks like. It's very common. You see osteophytes or subchondral sclerosis, subchondral cysts. Ignore the fracture there. And but the DJD versus AVN, this can sometimes be a problem. The subchondral cysts, though, of DJD can appear similar to AVN, but they usually have smooth margins. They're not serpentine like with AVN. They're usually on both sides of the joint, and the DJD, of course, is going to result in cartilage loss and osteophytes. AVN tends to be more serpentine or linear or curvilinear. It's usually anterosuperior in location when it starts, and the acetabulum is going to be unaffected unless it's end-stage disease, in which case you have both AVN and DJD. I want to spend a fair amount of time talking about acetabular labral tears. We're doing more and more MR arthrograms to look for these. It's an increasingly common entity following hip trauma. It may also occur idiopathically. It can cause persistent pain, mechanical symptoms, and probably accelerates degenerative changes. And it's more common in individuals with acetabular dysplasia. Now, the acetabular labrum is this fibrocartilaginous structure that lines the acetabular fossa, except inferiorly where it merges with a ligament called the transverse acetabular ligament. So it's sort of an inverted U shape. And this transverse ligament connects the anterior and inferior labrum, the anterior inferior labrum to the posterior inferior labrum. Here's an example on a sagittal cut showing that transverse ligament. Now, the normal hip joint capsule consists of both longitudinal and circular fibers. The longitudinal fibers consist of the iliofemoral ligament, the ischiofemoral ligament, and the pubofemoral ligament. There's also some circular fibers, which I kind of had to draw in here, called the zona orbicularis, which is around the neck of the femur and blends with the iliofemoral ligament anteriorly. Now, MR arthrography is really the best imaging modality for looking at acetabular labral tears. You inject anywhere from 8 to 20 milliliters of dilute gadolinium. We usually end up putting in about 15. And you put a surface coil over the symptomatic hip to get that good signal-to-noise ratio and resolution that you want. I recommend getting T1 weighted images with fat saturation then in the axial, sagittal, and coronal planes. And importantly, I get one in the what I call the axial, sagittal, oblique plane. This is parallel to the femoral neck. I feel this is a great plane to look at the anterior superior labrum where most tears occur. I also get T2 weighted images to look for cysts and loose body. Here's an example of that plane parallel to the femoral neck, and a look at the anterior superior labrum right there. The normal acetabular labrum is usually triangular in shape, but may have a round or flat free margin. It's normally of low signal intensity on all sequences. You can sometimes see a little bit of intrasubstance signal within the labrum, which represents some degeneration, but is not clinically significant. One thing to keep in mind is the iliopsoas tendon crosses just anterior to the anterior labrum and should not be confused for a labral fragment. It's easy to make that mistake, but if you follow it up and see that it's attached to the iliopsoas muscle, you won't get confused. The hyaline cartilage merges with the acetabular labrum and may extend under it very slightly, but usually it's not as dramatic as you might see with the glenoid labrum in the shoulder. You can also get these little sulci, normal sulci that can develop, and particularly in the posterior labrum. Some people say the anterior labrum, I'm not so sure of that though, but definitely in the posterior labrum near its junction with the transverse ligament inferiorly. Fortunately, labral tears aren't common here, so if you have this posterior labral little sulcus here, you can write it off as a normal variant. So let's look at some anatomy in this axial, sagittal, oblique plane going from superior to inferior. Here's the acetabulum, there's the top of the femoral head, there's your iliofemoral ligament, and your top of your zona orbicularis right there. Moving down, there's your anterior labrum, your posterior labrum with a little hyaline cartilage undercutting it right there, your iliopsoas tendon, your iliofemoral ligament, and your ischiofemoral ligament, and your zona orbicularis. Moving down a little further, there's that little sulcus I was talking about earlier, posteriorly near the junction with the transverse ligament. A little bit further, there's your fovea where your ligamentum teres attaches. There's your ligamentum teres. Inferior labrum, both anterior and posterior, as you see there. And finally, your transverse acetabular ligament, the underlying acetabular notch, and the ligamentum teres that inserts on your transverse acetabular ligament. Kind of put this all together on a coronal image, your labrum, your transverse ligament inferiorly. There's your ligamentum teres going from the fovea down to the transverse ligament, and your zona orbicularis seen in cross-section. So these acetabular labral tears are usually anterosuperior in location, although or maybe posterior in Asian countries. The tear is diagnosed if you see contrast displacing the labrum from the acetabular rim, or if you see contrast extending into the labral substance, as you see here, or if you just see a frank detached labral fragment. Here's an example of why I like these images parallel to the femoral neck. Here's a direct axial image, the most superior cut through the labrum. Kind of hard to see, and something doesn't look quite right about this anterior superior labrum. It's kind of hard to say what's going on. Here's the iliopsoas tendon. Labrum looks a little bit strange like there, but it's kind of hard to tell. So we look at our axial, sagittal, oblique images instead. And again, you can see that there's clearly a cleft going through that labrum, separating it from the underlying labrum. So it's a nice example of a tear. Paralabral cysts may accompany these labral tears. They actually are very specific. If you see one, look very, very hard for a tear. This is a T1 weighted image. You see this round structure here anterior to the labrum. They can be extra-articular if they pass through if the tear passes through the capsule. They're medial to the iliopsoas muscle, which will distinguish from an iliopsoas bursitis a little bit later, and adjacent to the acetabular rim. These cysts may also erode into adjacent bone. There's a T2 weighted image. You can barely see the labral tear here, and here's a cyst that's eroding into the bone right above it. And the same slice, essentially, but a T1 weighted image after intra-articular gadolinium shows the labral tear, and actually this is filling with some contrast as well. Talk about bursitis briefly. The diagnosis is really straightforward by clinical examination. There are two that we'll talk about, trochanteric and iliopectineal. Actually, there's several bursa in the hip. You have your subgluteus minimus, subgluteus medius, but most clinicians just all lump these together into trochanteric bursitis, so we'll do the same. You simply see homogeneous bright signal in T2 weighted images where you know there's a bursa. So the trochanteric bursitis is going to be around the greater trochanter, and this bursa can become inflamed by friction and trauma imposed by the tensor fasciae lata or iliotibial band rubbing over it. It can also be associated with tears of the gluteus medius or minimus. We don't typically give GAD to look for this, but sometimes it can be helpful if you're looking for subtle cases. Iliopectineal or iliopsoas bursitis is usually caused by excessive rubbing of the bursa by the iliopsoas tendon here. And because of the high frequency of connection between this bursa and the hip joint, anything that causes increased intra-articular pressure within the joint can result in this bursa. Here again, you see that the bursa is beneath or deep to the iliopsoas tendon. Here's the sartorius rectus femoris and tensor fasciae lata. Here's a nice example where we gave contrast, and you can see sort of this bursa forming a tail that goes into the joint with the iliopsoas above it. Finally, tendon and muscle injury. Just like anywhere else, tendons can degenerate, in which case you call it tendinosis, where you see focal or diffuse increased signal intensity. But you can also have partial or full thickness tears or avulsions, in which case there'll be high signal intensity in the tendon, both on T1 and T2 weighted images, and often with retraction of the torn tendon. Muscles can be strained, in which case you see bright signal on T2 weighted images at the myotendinous junction, or they can be contused, in which case you'll have focal bright signal on T2 weighted images in the muscle belly, or diffuse for that matter. And sometimes you can have a focal hematoma, variable signal intensity within it. Here's a nice example of a hamstring injury. This is a coronal image. Here's right ischium, left ischium on the right. You see the nice normal kind of V or W shape of the hamstring tendons inserting on the ischium on this side. It's a little bit less defined. You look at your T2 weighted images and you see why, that the tendon has been avulsed and there's high signal intensity separating the ischium from the hamstring tendon, unlike the normal side over here. These can sometimes be confusing. This is a patient who came into our tumor clinic with hip pain. A 15-year-old boy has this sort of vague ossification right here. On the MRI, you see that the ischium has low signal intensity on T1 weighted images, high signal intensity on T2 weighted images. But what you need to do is look very carefully at the hamstring tendon right here. You see there's high signal within it on this T2 weighted image. And in fact, this was simply just a hamstring avulsion injury. And if there's any question, you can always just get a CT, and that'll clear things up immediately. Obturator and adductor injury, I kind of alluded to this earlier. Actually, soft tissue injury is seen in about 50% of patients referred with a suspected femoral neck fracture. And this can really account for the pain. So that's why we get these T2 weighted coronal images with fat suppression. And if we see this obturator strain, we mention it because that can really be painful even if we don't see a fracture. Muscle contusions and hematomas. Here's a nice coronal image. It shows this large contusion in the gluteus musculature. There's this extra little mass right here. And on T1 weighted image, you see it has a little bit of high signal intensity, and that turned out to be just a little hematoma in the quadratus femoris, which eventually resolved. So in conclusion, MRI is a rapid, precise, and cost-effective means of diagnosing radiographically occult hip fractures. It allows the earliest detection of osteonecrosis and other marrow disorders, and it will frequently detect cases of hip pain involving the hip joint or surrounding soft tissues. Thank you.
Our next talk is on bone tumors and tumor-like lesions, and this is my favorite subject. It is a lot of material to cover, but everything should be included in your handout. What I want you to do is to spend time looking at the radiographs, the lesions. Now, we're going to begin with an evaluation of a solitary bone lesion. A lot of things in musculoskeletal radiology are what? Aunt Minnie's. How do you know what it is? It looks like your Aunt Minnie. It walks like your Aunt Minnie. You can recognize it from across the room. But what happens when you have a lesion that's not an Aunt Minnie? How do you approach it? And that's what we're going to talk about. What if it's a lesion you have no concept of what it is? What are the parameters? A lot of lesions are do not touch lesions. You don't want to biopsy them. The biopsy can be very confusing. For example, if you biopsy a healing stress fracture, the pathologist may see some very aggressive-looking osteoblasts and misdiagnose it as a tumor, as an osteogenic sarcoma, and that, of course, would be a travesty. And the pathologist needs to have radiographic correlation, so you need to come up with a most likely diagnosis. This talk is going to focus on plain radiographs because they give you the most information. We're going to talk about the uses of MR and CT briefly. Here's a patient with what? A non-ossifying fibroma. That's an Aunt Minnie. What's the worst case scenario? It fractures. Do you want to biopsy this? No. Now, when I came to the University of Chicago, I sort of was thrown into this busy orthopedic oncology service right out of my fellowship. And I was seeing all these bone lesions in real life that, I had only read about. And so a lot of things I didn't recognize. And so sort of just to defend myself, I developed a basic approach to solitary bone lesions. And this is what I need to know. I need to know the age, sex and symptoms, the location, the rate of growth, periosteal reaction, and matrix. Now, as far as sex of the patient goes, most primary bone tumors are going to be more common in males. There are only 3 paraosteal osteosarc giant cell tumor and ABC very slightly that are more common in women. Symptoms, most bone malignancies are painful. Some benign lesions are painful, but what you need to know is what's the character of the pain? Is it activity related? Does it wake the patient up at night? Is it acute or chronic? And those are the questions you need to ask the clinician. Here's a patient, a young patient. You can see the growth plates are open. You see cortical thickening here, and so your differential without any history would be stress fracture versus osteoid osteoma. But if the mother says, this patient has chronic pain that's been going on for 3 to 6 months. It wakes him up at night. He feels it's worse at night. It's not activity related. It's relieved with salicylates, and that's the classic history for an osteoid osteoma, and they actually do say that. Here's a patient who has a lucent lesion in the proximal humerus. You see a little density there, a little radiopig density there, and the mother says on this patient, the kid was fine till he fell off his bike, he had a pop, and then he had pain. And this is the classic fractured UBC with the fallen fragment. Now, you need to know what lesions are more common in what age groups. And the importance of knowing this is so you don't come up with a stupid differential. And you'll lose all credibility with your referring physicians if you have someone who's 80 years old and you put Ewing sarcoma in your differential. It just doesn't make any sense. Now, of course, there are always exceptions, and we always see exceptions. But this is in your handout, and I think this is a good thing to keep in the back of your mind all the time. If you look at malignancies of primary bone tumors, osteogenic sarcomas are going to be in young patients. Chondrosarcomas are going to be in middle-aged. Fibrosarcomas are going to be in older. Okay, and that can help you. Osteogenic sarcomas, there is a second peak in pagetoid bone and in status post-radiation therapy and probably in areas of bone infarction. If you look at Ewing sarcomas, they're almost always under 20. Chondroblastomas, epiphyseal lesions are going to be young patients. Osteoid osteomas are in the teens and 20s. Enchondromas actually last forever. Fibrocortical defects are in young patients, but they go away. You don't see old ladies with fibrocortical defects, so you're not going to put that in your differential. Aneurysmal bone cysts are young patients. Unicameral bone cysts, again, are not seen in old patients. The natural history is they go away, so you're not going to put that in your differential. Giant cell tumors, more common in women and usually in their 30s and 40s. Now, here we have 2 patients. One's 35 years old with hip pain. One's 16-year-old with hip pain. They both have epiphyseal lesions. Here's a lesion with a nice cortical margin sclerosis, but it's an epiphyseal lesion, and here's another one. And they look very similar. This patient, however, has a chondroblastoma in a young patient, and this patient has a clear cell chondrosarcoma. That is a variant of a chondrosarcoma that occurs in the epiphysis and usually 30 or 40 years old. So the age helps you with your differential here. Now, what about the location of the lesion? Is it metaphyseal, epiphyseal, diaphyseal? Is it cortical or medullary? Is it eccentric or central? This diagram is in your handout, and this is a diagram that I drew. But I think, again, this is one of those things you need to keep in the back of your mind. There are always exceptions, but at least you come up with a reasonable diagnosis or differential diagnosis. When you look at epiphyseal lesions, the big ones are chondroblastoma, intraosseous ganglion, and clear cell chondrosarcoma. Giant cell tumors arise in the metaphysis, cross the fused growth plate into the epiphysis, frequently will go right up to the subarticular bone. They're surface lesions like a paraosteal osteosarc and a periosteal osteosarc. Most malignancies are going to be metaphyseal. That's where the most mitosis take place. So you have osteomyelitis, METs, osteosarcoma, chondrosarcoma, fibrosarcoma, MFH, and Ewing's. No, enchondroma, sorry. Surface lesions like exostosis, osteochondromas point away from the joint. Non-ossifying fibromas and UBCs arise at the growth plate, but as the patient grows, they kind of migrate into the diaphysis. And this is a differential for diaphyseal lesions. In a young patient, Ewing sarcoma, eosinophilic granuloma, primary lymphoma of bone, multiple myeloma, and METs. Now, here's a patient with a lytic lesion centered in the metaphysis, crosses diffuse growth plate in a 30, 40-year-old woman. This is a giant cell tumor. The CT demonstrates no matrix, and we'll talk about that in a minute. But by location, this is a giant cell tumor, and this is the most common location for a giant cell tumor, which is distal femur. Now, what about rate of growth? You want to look at these lesions and you want to determine if you think it's benign or malignant. Now, you can't always, but it can be helpful to evaluate the margins of the lesions. Permeative lesions have a wide zone of transition. It's kind of difficult to tell where the tumor starts and ends, and this is on a plain film. Moth-eaten is intermediate, and geographic means there's a short zone of transition. This is normal, this is abnormal, can be sclerotic. Usually means benign, but sometimes low-grade malignancies like chondrosarcomas. Here's a diagram. This is a bone. This is a geographic lesion, short zone of transition, moth-eaten and permeative. And if you look at this patient with a lesion in the calcaneus, you see this lucent lesion, short zone of transition, normal bone, abnormal bone. This is a benign lesion. It's a unicameral bone cyst, common location. Here's an intermediate pattern, sort of a moth-eaten pattern. There's a fairly wide zone of transition. This is a giant cell tumor. It's centered in the metaphysis, goes into the subarticular bone. Here's a patient, a young patient that has a lesion that is very hard to see, even on the original radiographs. And that's because it is so aggressive and so permeative. If you look up here, you can see normal cortex and medullary space. But when you get down in this part of the diaphysis, it all gets kind of blurred out. And this patient had a Ewing sarcoma. Now, what about periosteal reaction? That's the next parameter that I want to talk about. Well, the periosteum on a normal plain film is soft tissue density, and you're not really going to be able to see it. But sometimes you can tell, or at least have an idea about the underlying insult if you look at the way the periosteum is reacting. I mean, the periosteum can be elevated by blood, pus, tumor, edema, and after 7 to 10 days, it starts to ossify. A single layer of periosteal reaction is pretty nonspecific. We see it in fractures all the time, but it's seen in osteomyelitis and sometimes benign tumors, but rarely malignancies. Onion skin is a little bit more ominous, usually repeated insults. The two biggies are osteogenic sarcoma and Ewing's. Perpendicular spiculated sunbursts, they're almost always malignant. And Codman's triangle, when the periosteum is elevated up in a triangle, is also a very ominous sign. Here's a diagram. This is a bone with single layer periosteum, a bone with onion skin or laminated periosteum, a bone with sunburst or perpendicular or spiculated periosteal reaction, and here's a Codman's triangle. So if you look at this patient, this one's kind of hard to see. There is a little bit of periosteal reaction here, and actually it doesn't project well, but here too, in the diaphysis in a young patient, and this is a Ewing sarcoma, even though you cannot see the underlying lesion very well. This one's a little clearer. Here's another Ewing sarcoma. You have a diaphyseal lesion, it's in here somewhere, but what you're seeing is this onion skin periosteal reaction, multiple layers of periosteum. You're getting sort of a Codman's triangle here. You can see that periosteum very well. And this is a Ewing sarcoma. This is a patient with an osteogenic sarcoma. And what we're getting here is a Codman's triangle, perpendicular periosteal reaction. And our next parameter that we're going to talk about is matrix, tumor matrix. And here we see this sort of amorphous mineralization. Tumor matrix, there are basically three that we see, and then a pertinent negative is no visible matrix. Osseous matrix is cloud-like or amorphous. Cartilage matrix is punctate and C-shaped. Fibroosseous is our classic ground glass. Here's a patient with a sunburst pattern. It's a osteogenic sarcoma, and there's sort of all this mineralization in it. Here's another patient. You can see this intramedullary sclerosis. This is an osseous matrix with somewhat amorphous mineralization. MR doesn't really help us other than to tell us the extent of the lesion. We're going to talk about MR in a second, and CT. Now, this is a cartilaginous matrix. You're getting little punctate calcifications in here. Now, sometimes you can't tell the difference between cartilage and osseous matrix, but you certainly want to. This patient, for example, definitely looks like cartilage. A biopsy would not be helpful in this patient. If the patient is symptomatic, then you probably would go in, do a frozen, and do the definitive surgery at the same time. Because the treatment is different from an osteogenic sarcoma, where you want to give chemo. Here's a patient with all these little punctate calcifications. This is a cartilage lesion. How do you know if it's benign or malignant? Sometimes you can't tell by the radiograph. Sometimes you go with the patient's symptoms. Is it painful, not activity related? Sometimes you can see cortical destruction, but not always. This patient, I don't see any cortical destruction, but they went in, did a frozen. It was cartilage. It got cut out. This is cadaver bone. This is an allograft. Here's a patient with a lesion arising from the condyle. CT is very helpful in showing us these little punctate calcifications in a cartilaginous lesion. This was a chondrosarcoma. Cartilage, this was a benign enchondroma. The patient was asymptomatic, but again, we had these little punctate calcifications. Now, the third sort of lesion matrix is what's called a ground glass, where the trabecular pattern gets sort of smudged out. It's not purely lytic, but it's just kind of ground glass, smudged out. And it's most common in fibrous dysplasia, but you can see it in other lesions. Low-grade osteogenic sarcomas can sometimes be ground glass, but by far the most common entity is going to be fibrous dysplasia. Here's a classic fibrous dysplasia, ground glass, maybe a little bit expansile, but certainly a benign lesion. Here's a patient with a Shepherd's crook of fibrous dysplasia. And again, the trabecular pattern is just kind of smudged out. Now, what about CT? And we do CT in a lot of these patients after we've looked at the plain film. The role of CT is really looking at lesions that are hard to see. The pelvis, the sacrum, and the scapula are extremely hard to see on a plain film. It helps us distinguish cortex from medullary lesions. It helps us with cortical destruction, and it helps us with tumor matrix. Here's a young guy. No, this was an older patient. I'm sorry. This guy's like 70 or 80. He has a lesion in his ilium. If you look at the normal side, you can follow the crest back behind the sacrum. You look on this side, and it just kind of disappears. This patient had lung cancer, has a huge lesion that is very hard to see on a plain film. This is a young patient that came in with this lesion in the mid-diaphysis of the humerus. Is it cortical or is it medullary? Does it have matrix? Well, the CT is very helpful here, and it shows us there is a surface lesion with punctate calcifications in it, and this is a juxtacortical chondroma. Now, the role of MR is basically for seeing the soft tissue extent and evaluating the marrow extent for therapy. It usually adds very little diagnostic information. Here's a young guy, and this guy is about 18 or 20. He comes in with this lesion, dense sclerotic bone in his ilium. This is an osteogenic sarcoma, unproven otherwise. What type of surgery does this patient need? What's the extent of this lesion? Does he need a hemipelvectomy? This is, here's his CT, and you can see this extensive soft tissue mass, periosteal reaction. The MR, this is an old MR, this is a T1. You can see that all of the pelvis is involved. Can you save the joint? No. Soft tissue mass on a T2. Here's a young patient that comes in with dense metaphysis. It's, again, an osteogenic sarcoma and proven otherwise. What can you do for this patient? What's the extent of the lesion? You do an MR, and you can see this is where you're going to have to cut off the femur. Can you save the growth plate? No. Here's a young patient with a sacral lesion. Even on the original films, it's hard to see. CT and MR demonstrated this, and this has actually fluid levels. This is an aneurysmal bone cyst. But fluid levels are not pathognomonic of aneurysmal bone cysts. We're going to talk about them. This was a patient that has fluid levels who had an osteogenic sarcoma and got a total knee. Now, for the next half an hour or so, I want to talk about specific lesions. And the way it's organized is we're going to talk about lesions that produce osteoid, benign and malignant, cartilage, benign and malignant, fibrous, benign and malignant, giant cell tumors and cysts, miscellaneous lesions. Okay? And I've put the most important lesions at the beginning, so if we don't get to some very bizarre lesions at the end, they're in your handout. But we'll talk about these common lesions. Now, osteoid osteomas we see not uncommonly. These are the patients, like we said, who come in with night pain. They're young patients, usually in the lower extremity, 50% in the tib fib, but they can also be in the spine, and those patients present with a painful scoliosis. So if you have a kid that comes in with a painful scoliosis, most adolescent scoliosis is not painful. Think about osteoid osteoma and see if this pain is activity-related or non-activity related. The etiology is unclear. People really don't understand what this lesion is. Maybe it's just reactive, but we treat it like a benign neoplasm. Dull pain worse at night. Usually quite a while of chronic pain before the diagnosis is made. When it's intra-articular, it may look like an arthritis, and since they're young, these you think JRA, because they can get a reactive synovitis. Natural history of an osteoid osteoma, it'll burn itself out. If the patient can tolerate salicylates for several years, this lesion will eventually burn itself out. On a radiograph, you see reactive sclerosis and a leucinitis. It may have a central calcification. MR, because of all the reactive edema, can be very misleading. Our treatment options are medical, surgical, or radiofrequency ablation. And more commonly, this is our preferred option. Here's the patient we saw earlier, cortical thickening. With CT, you can identify the nidus. Here's a young patient that floated around, unfortunately, at our institution for a while. And the radiographs were always read as normal. I think, in retrospect, there is a little lucency there, and CT shows the nidus. This was an osteoid osteoma. Again, here's another patient with a nidus that's identified on CT. Here's one in the spine. Unfortunately, I don't have the cross-sectional imaging. The patient presents with a sclerotic pedicle in a very young patient, painful scoliosis. Edema on MR, like I said, can be very misleading. I think here you see the cortical thickening. I think the study of choice would be a CT through there to identify the nidus. Now, this is what we're doing now, these radiofrequency ablations. We drill into there and put the probe in and zap this lesion. Here's another patient that has this nidus. There it is on CT, and here it is with the radiofrequency ablation probes in it. Now, what about osteoblastoma? Think of it as a giant osteoid osteoma. They're much less common. They're less painful. They have less sclerosis. And they have a larger nidus, greater than 1.5 or greater than 2. They can have multiple internal calcifications. And these frequently occur in the posterior elements of the spine. Here's a patient with an osteoblastoma that's back here. This was an unusual one in the talus. You can see this lesion with a nice sharp margin, a geographic lesion in the talus. Here's a CT and T1, T2, and this was an osteoblastoma. Here's a patient that has pain in the hip. You really can't see anything on the plain film, but you do the CT, and here's the osteoblastoma. And sometimes, like I said, they have multiple little calcifications in them rather than just a single calcified nidus. This was EMR on that same patient. Now, let's talk about the bad things, osteogenic sarcomas, and there are different types of osteogenic sarcomas. Classic medullary is going to be the most common. There are two surface lesions that I want you to know, paraosteal osteosarc and periosteal osteosarc. There's a low-grade medullary, there's a high-grade surface, there's a telangiectatic, and we'll talk briefly about secondary osteogenic sarcomas. I like the Clint Eastwood approach to osteogenic sarcomas, the good, the bad, and the ugly. What are the good ones? If you're going to get an osteogenic sarcoma, get a low-grade one. Get a paraosteal or low-grade medullary. The bad ones, pagetoid or radiation-induced, these have a terrible prognosis. Usually we don't do anything heroic for these patients. And then there are the ugly osteogenic sarcomas, the telangiectatic, because they are very aggressive, but they're not so bad because they respond to chemo. They used to be bad, but now they're just ugly. Okay, classic osteogenic sarcoma, 10 to 25, metaphyseal, most common at the knee. And that's where the most growth occurs in long bones. It makes sense. You have more mitosis, you're going to get more chances of malignancy developing. They usually almost always have pain, and they can have an elevated ALK Phos. Cloud-like dense bone formation, medullary metaphyseal, can have an interosseous mass. Classic is sunburst. They have a prognosis poor prognosis if they have discontinuous lesions at presentation. So you want to do bone scans. We're not going to talk about bone scans today, but you don't want to do bone scans on these patients in their general workup to make sure they don't have osseous metastasis at the time of presentation. Here's a patient with a classic sunburst of an osteogenic sarcoma. Here's a patient with dense bone. You can see there's a little bit of soft tissue ossification here. This patient has replacement of the marrow here with tumor on a T1, bright on T2, and this patient got resection of his proximal femur. Here's another patient that really did not do his chemo, and he progressed with a large soft tissue mass with ossification in it. And here's another patient with very, very dense bone, sort of fluffy, and there's his cut specimen. This is a recent case last week of a patient that came in, and you can see this periosteal reaction here. The bones are a little bit dense. It's a little unusual in the fact that it's diaphyseal. So like I said, you'd like to see it here. But there is some ossification in this soft tissue mass. And this, again, was a pathologically proven osteogenic sarcoma. This is just her MR. It really doesn't do much for you, but show you there's not much of a soft tissue mass and that it's a very long extent. This patient has a lesion arising the fibula, and you can see the marrow's replaced. Unusual case in a lawyer who presented with this painful lesion. And this was an osteogenic sarcoma arising in a metacarpal. Here's his MR, bright signal, bright soft tissue mass, and that was a cut specimen on this unusual osteogenic sarcoma. A very lucent lesion in this kid with not much matrix, but there was a bone metastasis at the time of presentation. You can see it's hot on the bone scan, skip lesion. Okay, paraosteal. Let's talk about this surface lesion. Like I said, this is one of the very few bone tumors that's more common in women. The age is 5 to 10 years older than your classic medullary. Surface lesion, better prognosis. Again, the knee is the most common location. They present with pain, and radiographically we see this amorphous cloud of mineralization, and this is a typical patient with the most common location for paraosteal. Now, just could this be anything else? Well, could it be myositis ossificans? Well, you notice how this is ossifying. It's ossifying sort of centrally first. Myositis ossificans tends to ossify around the periphery first. And you should be able to separate from the bone. If you look at this, unfortunately, there's a mark on here. You can see this soft tissue mass back here posteriorly. Here's another patient with a very dense paraosteal osteosarc. Another one that's very dense, and this one kind of wraps around. It's hard to tell if there's medullary involvement, but on the CT, you can see it's purely a surface lesion. Another patient with a paraosteal, another paraosteal, and the other surface lesion is a periosteal. What's the difference? Well, periosteals tend to be diaphyseal, okay, rather than metaphyseal. Same age as your classic medullary, a little bit of better prognosis. They're also very, very uncommon. Here's a patient that came in with these outside radiographs. There's a little bit of periosteal reaction here, maybe a little bit right there. Doesn't project well. Came in with this CT. You can see there's some mineralization there, a little something on this outside MR. This is a T1 and a T1 post-contrast. And you can see the medullary space is normal. There's a diaphyseal lesion that's purely a surface lesion. She was treated with allograft. This is cadaver bone from here to here. And she did quite well. This is a cut specimen. Again, you can see it's purely a surface lesion. And there's intra-opt. Again, she has allograft that goes from about here to here, cadaver bone. Telangiectatic, remember I said it's ugly. It's very aggressive. You usually do not see any sort of mineralization in it. It looks purely lytic, but it does respond well to chemo. Sometimes these lesions have fluid levels in them. Okay, so that's sort of typical in a very aggressive lesion with blood-filled cyst in it. Now, what about this patient? As we get on to secondary osteogenic sarcomas, this is a patient with what? Paget's disease. Typical bone scan in an older patient with Paget's disease. You can see on the plain film, thickened cortex, accentuated trabecular pattern, but this is a pagetoid sarcoma. Like I said, very, very poor prognosis. Here's a recent patient, I think last month or month before, who came in with these radiographs in pain, has cortical thickening, looks like Paget's disease, but what about that? If you look very closely, there's an ossifying soft tissue mass. And again, this patient was not treated with any heroic measures and was not even operated on once a biopsy was done. This is a recent patient, too, that came in to the ER. Actually didn't have any pain here, which is amazing because she had severe neuropathy. But this is a patient that was irradiated in the past for a pelvic tumor, and now she has a secondary osteogenic sarcoma. So an elderly patient with this fluffy mineralization. And here it is on CT. You can see it's destroying the acetabulum. Now, let's talk about cartilage lesions. Common benign lesion in chondroma. The most common benign lesion of the small tubular bones of the hands and feet. The important things to remember is they're usually geographic, frequently have calcifications in it, and probably most important of all, unless they have a path fracture or are undergoing malignant transformation, they're going to be asymptomatic. They should be asymptomatic. Okay, painless unless fracture. Geographic lesions, punctate calcifications. In the small tubular bones, they can be somewhat expansile. That's okay, but they shouldn't break through the cortex. And there's a syndrome of multiple enchondromatosis, Olier's disease. They usually present with a growth disturbance, especially if it's in the lower extremity. Again, they really shouldn't be symptomatic unless they fracture or undergo malignant transformation. It's not inherited. 1/3 of patients with Olier's will undergo malignant transformation, and there's a syndrome called Maffucci's that's multiple enchondromatosis and soft tissue angiomas. These patients will die of cancer. Okay, if you have Maffucci's, you'll die of cancer. It may not be a chondrosarcoma. It could be a carcinoma, but you will definitely die of cancer unless you get hit by a truck first. I guess that could happen, but you know. Okay, here's a typical enchondroma, expansile, asymptomatic, incidental finding. Leave it alone. Don't biopsy it. You'll just get into trouble. If you want to make this malignant, you can biopsy it, send it to Mayo, and they'll call it a low-grade malignancy. So pathology, you know, I always think it was the exact science, you know, black and white. It's not. There's a continuum in pathology just like any place else. Don't biopsy this lesion. Here's another typical enchondroma, sclerotic margin, asymptomatic patient. Another one that looks very same with a little central calcification in it. Another one, this one actually had a path fracture, although I'm not sure it projects. This patient has multiple calcifications, multiple enchondromas, and let's see, there and there. Here you can see on this magnified little punctate calcifications in an asymptomatic patient. This one is an old slide, but shows this growth disturbance in a patient with Olier's disease. Here's a patient with Olliers disease with lesion in the pelvis. This is that same patient with this growth disturbance, these cartilaginous rests that are in the medullary space. Again, you can see how this patient would present with a limb length discrepancy. This is a patient who had this lesion. You can see she had a very short humerus. That wasn't so bad. What was bad is that she also had this lesion in her distal femur that was malignant. So she was an Olliers disease that developed malignant transformation into a chondrosarcoma. If you look at her MR, here's her chondrosarcoma. That's a benign enchondroma. This one's breaking through the cortex. Here. This is a patient with Maffucci's, multiple enchondromas in the hand, and soft tissue hemangiomas that you recognize by the multiple phlebolas. And there's a plain film. Now, what about other benign things? Juxtacortical chondroma are not nearly as common as enchondromas. Solitary benign, surface lesions. They can have symptoms, and they can have a soft tissue mass, but again, they're benign. Here's one that's causing some saucerization of the underlying. This is one that we looked at earlier, and so they usually get operated on because they're symptomatic. Chondroblastomas, the important thing to remember about chondroblastomas is what? The young patients have epiphyseal lesions. 50% have calcifications radiographically, more on CT. They can present with pain and joint effusions. And here's the patient that we looked at earlier, a young patient with an epiphyseal lesion. CT shows you a nice geographic margin, internal calcifications. Here on MR, T1 and T1. And here's one that was in the proximal humor here. Now, other cartilage lesions that are benign, chondromyxoid fibromas, they're very rare, 1% of bone tumors. You probably won't see one. They tend to be metaphyseal, going right up to the growth plate, and they're typically soap bubbly, multiloculated, geographic. Usually you do not see calcifications in them, at least on a plain film you don't. And most common in the lower extremities. And here's your classic sort of soap bubbly type appearance. Here's one that was in the metatarsal, but it has that classic appearance, goes right up to the growth plate. Other benign cartilage lesions, osteochondromas, are common. Very common. They tend to occur around joints. They point away from the joint. You can follow the normal medullary space into these things. Their symptoms in kids are usually mechanical. These adolescents know they have a hard mass, say, at their knee. So they're usually very much aware that they have an osteochondroma. Malignant transformation occurs when you start having pain or growth after a patient is skeletally mature. I mean, that's a sign. These enchondromas should not be growing in an adult. There's a syndrome of multiple hereditary osteochondromatosis. They have perhaps a 20% chance of malignancy. So those have to be watched to make sure they're not growing. Autosomal dominant, incomplete penetrance. And here's a patient with a typical osteochondroma pointing away from the joint. And you can see, because they're around joints, that they can cause mechanical symptoms. Here's sort of a broad-based one. But again, if you do cross-sectional imaging through here, you'll see normal marrow going out into this lesion. And here's another one. And this patient was unusual, and it's the only one I think I can remember seeing that actually fractured. They don't usually fracture, but they can. So this patient, we had normal exostosis, osteochondroma, that developed pain because of a fracture. Here's a very broad-based one. Here's our patient with multiple hereditary exostosis. Frequently in the femurs, you'll see sort of a wide neck. That's pretty characteristic. Here's a big exostosis there. And here's another one that's sort of typical, pointing away from the joint, but this patient has multiple exostosis. And this is that same patient. Look at all these exostoses coming off. Now, I just want to mention briefly BPOP, which is sort of a funky exostosis. And I put it in here because no one really knows where it goes. Bizarre paraosteal osteochondromatous proliferation. So if you see in the hand what looks like an exostosis, but it's very funny looking and painful, think of a BPOP. It's also known as Nora's lesion. They have a high level of local recurrence. There. And here it is, just a funky looking exostosis. You can see that it's fairly well ossified. Okay, let's talk about malignancies, chondrosarcomas and chondrosarcoma variants. They can arise secondary. We just talked about osteochondromas and enchondromas. The age is older than an osteogenic sarcoma, so we're saying 40 years old. You look for the calcifications for the matrix. They can have sclerotic margins, so they can look sort of benign, but they should be symptomatic. Here's a patient that we saw earlier with this lesion that had these punctate calcifications. And here's a patient with this lesion, punctate calcifications, and was symptomatic. Here you can see the marrow has been replaced with tumor. And here's a patient with cartilage lesions. Chondrosarcoma variants, be aware of clear cells. The only thing you need to know about clear cells is that they are epiphyses. So you have a 40-year-old with an epiphyseal lesion. It's something to think about. Dedifferentiated chondrosarcomas are lesions where there's both high-grade cartilage lesion and low-grade cartilage lesions. And what you might see in these dedifferentiated, suppose you have a cartilage lesion that looks sort of benign, but over time the patient starts losing that calcified matrix. That's actually a very bad sign, meaning that you're going to a more anaplastic tumor. Here's our clear cell chondrosarcoma, and there's a cut specimen. Here's a patient with probably a dedifferentiated. This is well calcified, but what about this part? The patient lost calcifications there, and this is the more aggressive lesion. This patient was watched over time. You see all these punctate calcifications, it's cartilage. Is it benign or malignant? Well, your best bet is to talk to the patient, and is it symptomatic? But if you look at this patient over time, I think we thought that it was rotator cuff pain that the patient was complaining about. But if you look at this patient over time, this had nice cortex, and then she started to destroy her cortex. So this was a chondrosarcoma. And the MR shows the soft tissue mass. And so the treatment for these is purely surgical. Chemo doesn't work for chondrosarcomas, and radiation doesn't work well either. Here's a patient, again, with punctate calcifications here, and she got an allograft. Okay, let's talk about fibrous lesions as we wind down. Probably the most common benign fibrous lesion we see is a non-ossifying fibroma, NOF. Same thing pathologically as a benign fibrocortical defect, except the benign fibrocortical defects are, of course, in the cortex. Some people call these fibroxanthomas. That's fine. They arise in young patients. Up to 40% of children probably have these, and they're asymptomatic unless they fracture. And the natural history is they go away. So do you need to biopsy these? No. The worst case scenario, they fracture. Do not biopsy. There is a syndrome, Jaffe-Campanacci syndrome, where the patients have multiple non-ossifying fibromas and cafe-au-lait spots, but the natural history of these NOFs is the same as your solitary NOF. Here it is. Nice sclerotic margin, eccentric, no matrix, no periosteal reaction, asymptomatic. Here's another one. It's an Ant Mini. Here's another one that got an MR for another purpose. And you can see it's low on T1, and it's a little bit mixed on T2. Here's a patient with Jaffe-Campanacci. These look like your just run-of-the-mill non-ossifying fibromas, except that they're multiple. And here's one. And here's one that's fractured. Worst case scenario. Now, what about other benign fibrous lesions? Fibrous dysplasia is not uncommon. 25% of fibrous dysplasia is going to be polyostotic, meaning 75% is monostotic. There is a syndrome of Albright syndrome where the patients have cafe-au-lait spots, polyostotic fibrous dysplasia, and endocrine abnormalities, the most common being precocious puberty. And there's also a syndrome called Mazza-Brod's where they have polyostotic fibrous dysplasia with intramuscular myxomas. And I just want to make you aware of those two entities. Fibrous dysplasia tends to be unilateral. They can present with deformity, sometimes pain because they have a fracture. But usually we have a nice ground glass. The classic finding in the hips, of course, is the shepherd's crook deformity. And here we can see this fibrous dysplasia ground glass. Here again, sort of a ground glass appearance in a patient with fibrous dysplasia, ground glass, fibrous dysplasia. Here's a patient with a Shepherd's Crook deformity. She had polyastotic fibrous dysplasia, and you can see this abnormal trabecular and a ground glass deformity. Now, occasionally, fibrous dysplasia can involve the skull or the frontal bones, and it's called leiomyositis ossea. They get marked deformity. This patient looks like she's wearing a helmet, but that's just fibrous dysplasia involving the cranium. Maserbrad syndrome, polyastotic fibrous dysplasia with intramuscular myxomas. Here you can see this intramuscular mass, and you can see that there's fibrous dysplasia in the humerus. You can see it here on the MR, and a soft tissue mass. This is another patient with Maserbrad's, fibrous dysplasia, and an intramuscular myxoma. Now, what about another entity that's much less common, osteofibrous dysplasia, or ossifying fibroma? This is, you can think of it as intracortical fibrous dysplasia. It occurs in almost exclusively the tibia. You can have a ground glass appearance, but it's cortical. Usually painless. It may be related to an adamantinoma. There may be some crossover lesions from an ossifying fibroma or osteofibrous dysplasia to adamantomas. Because what? They both occur in the tibia almost exclusively. And here's a patient with this lesion in the tibia that was an ossifying or osteofibrous dysplasia. And here again, eccentric, cortical. Okay. Now, let's talk about the two malignancies, MFH and fibrosarcoma. The important thing to remember about these are the pertinent negatives. Usually these lesions are so aggressive you don't have periosteal reaction. You don't have time. No matrix. Okay? So usually metaphyseal. They can arise secondary to other lesions like infarcts. But again, aggressive lesions, no matrix, no periosteal reaction. So here, this is one that came in just a couple weeks ago. It's just an aggressive lesion that is breaking through the cortex. Okay, there's no way you could say this was an MFH. In this older patient, I would have put METs long before I put a primary bone tumor. Here's another just aggressive lesion. Here's one with a path fracture. Here's another just aggressive lesion. Here's one that arose in areas of bone infarction. And there are all these densities here that are bone infarcts, and the MFH arose from these bone infarctions. Okay. Now, let's shift gears and talk about cyst and giant cell lesions. Giant cell tumors are not uncommon. They tend to occur the distal femur, proximal shoulder, and distal radius. And we'll just go through no matrix, distal femur, radius, and humerus, and can occur in the sacrum. Here's a patient that has one here. No matrix, the location is great. Here's another one, very typical. They can occur in the small tubular bones of the hands and feet, but they typically go down to the subarticular bone. They can have sclerotic margins, but it's not common. And here's another one, okay, an MR. Here's one in a radiologist that ordered his own film. So these patients are usually 35 or 40 years old. Now, a related lesion called giant cell repair granuloma, these occur almost exclusively in the small tubular bones of the hands and feet. They look like giant cell tumors, but they don't break through the periosteum, so there's no soft tissue mass. Okay, that's common benign lesion, like NOFs. They go away. Worst case scenario, fracture, sclerotic margins, young kid. Fallen fragment sign is pretty much pathognomonic. We saw that. The treatment is either to observe, because they go away, inject with steroids, or to pack with bone graft. And here's a patient that has one here. This patient was taken to the OR. They put steroids in here. Here you can see there's an air fluid level as they were aspirating this fluid out. Here's one in the calcaneus, very common location. Here's our guy with the fallen fragment sign. He has it, you can see it on MR. Okay, and there again, that was a post-GAD. Typical unicameral bone cyst. Now, what about aneurysmal bone cyst? unlike UBCs, aneurysmas are frequently painful, they're expansive. People don't really understand what they are. They can arise de novo. Maybe there's some sort of AV malformation. But they can also arise secondary chondroblastomas, giant cell tumors, non-ossifying fibromas, osteoblastomas, chondromixed fibromas, and fibrous dysplasia. Okay, so they don't. Aneurysmal bone cysts, always be careful. If you see something that looks like an ABC, don't just blow it off as an ABC. There may be an underlying lesion. ABC, always be careful. Usually young patients. Here's a patient with a very aggressive-looking aneurysmal bone cyst. And on these coronal images, you really can't see the fluid levels, but this patient did have fluid levels. Fluid levels are not pathognomonic of ABCs. They can be seen in telangiectatic, like we mentioned, MFH, fibrosarcomas, and even in fibrous dysplasia. Here's a patient with a very expansile lesion in the sacrum. Here's another patient with pain. This was a fairly recent CT, low on T1, bright on T2. This is with post-GAD. This fluid does not enhance. And here we are. Here's a nice fluid level on a T2 weighted image. Here's a case with an ABC here. And actually, he had a fluid level. Okay. Interosseous lipoma is benign. You see a lesion that has fat in it. We're seeing them more and more on CT and MR. May have central calcifications. Here in the calcaneus, it's right where you see a UBC. That's why some people think they're related. But you tend to have this dystrophic calcification. This is another do not touch lesion. Here you can see this lesion here that is fat on a fat sat, and a T1 you can see that's also fat. Here's one that has a very sclerotic margin here that's also an interosseous lipoma. You can see there's fat in it. Interosseous ganglions, when you see something that looks like a subchondral cyst, but the patient doesn't have OA, think interosseous ganglion. Most common is going to be medium allelis. Okay, looks like a cyst, but no arthritis. They're younger patients. They can be symptomatic. Here's the most common location. It comes right up to the subarticular bone. Looks like a huge multilobulated cyst, but the patient doesn't have any OA. And here's one, again, in a relatively young patient that was about 30 years old. And in the MR, you can see it's multilobulated. Ewing sarcoma, we need to talk in the next 30 seconds on small blue cell tumors. Ewing sarcoma, common primary bone tumor after osteogenic sarcomas, usually under 20, rare in African Americans. So if you have a black patient, it would be unusual to have a Ewing sarcoma. They tend to be diaphyseal. Onion skin we've already talked about. There are variants. We're not going to talk about PNETs. But here's your typical onion skin periosteal reaction. Periosteal reaction, the lesion's hard to see. We solved this one. And those are typical Ewings. Here we are. This is a biopsy site. Here's one of the calcaneus. Here's one in the fibula. Okay, here's one here. Primary lymphoma bones look like Ewings, but they're in a patient that's 30 or 40 years old. So it looks exactly like a Ewing's. Multiple myeloma, the most common primary lesion of bone. And we'll end with this. They present with pain and weakness or neurological symptoms. I think that's important that they can present with neurological symptoms first. They come from the neurologist. Typical picture is punched out lesions, cookie cutter lesions, but they can be diffusely osteopenic. But be aware that myeloma rarely can be sclerotic. Bone scans are unreliable. MR can even have false negatives. Here's a patient with a typical punched out lesions. No one will mistake that for anything else. Here again, punched out lesions in the skull, multiple myeloma. Punched out lesions, here's a CT in a patient with myeloma. But be aware that myeloma can be sclerotic, and be aware that there's such a thing as POEMS syndrome, where the patient has polyneuropathy, organomegaly, endocrine abnormalities, M-protein, skin lesions. They usually present with this polyneuropathy, and they have sclerotic myeloma. And here's a patient with multiple foci of myeloma. And we'll end with this picture of myeloma, again, sclerotic. So what I want you to take, we went over a lot of different tumors today. What I want you to take away, though, is that basic approach. You know, be able to look at matrix, be able to look at zone of transition, do you think the lesion is benign or malignant? Okay, thank you very much.